Hello and welcome to this second Investigate session that will look at the General Planning Model and the PRECEDE-PROCEED Planning Model in more detail. This is the second session of the Planning and Implementation for Health Promotion and Public Health module. In this session, we're going to look at the General Planning Model in more detail. We're going to look at the PRECEDE-PROCEED model in a bit more detail, and we're going to look at, in particular, the strengths and weaknesses of each of the models, as well as the similarities and differences between the two models. The General Planning Model in a bit more detail. So, as you remember from the last session, there are 7 steps or stages in the General Planning Model, and most models, project planning models, as well as if you think back to policy and evaluation and a healthy public policy module, these steps are similar to the steps in the policy planning process. So, the General Planning Model has 7 steps. Understand your community by doing a needs assessment. Set a goal or aim and some objectives. Identify the methods and approaches you're going to use, the specific activities that you will have in your project to achieve your aim. Identify what resources you need. Plan and design the evaluation methods, develop an implementation action plan, and then implement and evaluate your project. So if we start with step 1, understand your community, do a needs assessment. Without understanding the needs of a community and community groups, we cannot successfully design and deliver a health promotion project. We need to understand people's existing behaviours, their existing behavioural needs and behavioural assets, i.e. the positive behaviours they have are their assets, and the negative or risky behaviours they have are their needs in terms of how we can help them to improve their health and well-being. We also need to look at their existing health problems, whether they have a chronic condition, whether they have a disability, or whether they have some other health issue that stops them from taking part in positive, healthy behaviours. Then we need to understand their existing knowledge and skills, and again, that's an asset. We can work in a project to improve their knowledge and skills. And lastly, the social, family, cultural, economic, environmental background around individuals that again can help them to have positive health behaviours, but that can also be barriers to them having healthy behaviours and may even enable them and predispose them to undertake risky behaviours. Also, without understanding the needs of communities and groups within communities, we cannot successfully evaluate a health promotion project because we don't have a baseline. We need a baseline of what the existing community is like, what their existing environment is like, what their existing behaviours, what existing assets, resources, skills, knowledge they have. And from that baseline, we can then see what we can do with our health promotion or public health project. And then after the project has run for a while, for a year or 2 years, we can then evaluate that project and see if there's been a change in people's behaviours, their knowledge, their skills, and their wider environment to be more positive, to help them and support them to improve their health and well-being. And if a project does not meet people's needs and does not improve health and well-being long term, then that project is really not worth doing. So that's why it's really important to do that needs assessment, to provide a baseline understanding so we can make sure that the project is appropriate and meets the needs or works with the issues that the community are grappling with, as well as to evaluate it afterwards by having this baseline information that we can judge whether our project has enhanced people's skills and abilities and resources in the community that are there to improve their health and well-being. Just a little bit of background, you already have come across definitions of needs assessment. So needs assessment is a systematic process for determining and addressing needs or gaps between current conditions, where people are currently at, and what their health behaviours and environmental conditions, social, physical, economic, cultural, are, and the desired conditions or wants, both of communities as well as public health professionals. The discrepancy between the current condition and the wanted condition must be measured to appropriately identify the need. Now, this is an example of some community consultation that I was involved in, that I led and designed. You can see my colleague here, Laura, with some children, and they are looking at a street in Queen's Park, London, and we're looking at how we can make that street, that road, safer. And we're getting local communities involved, children and adults involved in redesigning their street and how we could improve the safety along that street. And the second one is the kind of epidemiological assessment that we have looked at before. That's with the public health profiles, the local health profiles that we looked at in assessing population health. So this is also an important aspect of needs assessment, that we look at the information about an area at ward level, at district local authority level, and at national level, depending on the size of the project. Normally we're looking at ward or local authority level and the information there, and much of that information can also be found in the joint strategic needs assessment that all local authorities currently do. So in needs assessment, what are we measuring? Well, we tend to measure four things. We measure demographic indicators: age group, sex, ethnicity. What are the over 65s, the percentages, the numbers of people over 65, the numbers of children under 5. And we also look at health status, life expectancy, healthy life expectancy, number of hospital admissions for hip fractures, number of traffic accidents in that local authority area, the number of people dying early of cardiovascular disease or dying of cancer. And then we also look at determinants such as educational achievement in children, whether they're achieving ABC grades at GCSE level, the percentage of obesity and overweight at reception year 1 and at year 6 in primary school, the adult and child physical activity levels, and also air pollution levels are an example. And we also look at health inequalities, and that's through the index of deprivation, for example, the 2015 and the current 2019 versions of the index of multiple deprivation. And the steps in doing a needs assessment are 4 key ones. Determining the scope of the assessment. So you normally work with an advisory committee who are part of your project, and they are made up of a range of key stakeholders, members of the target community, key professionals working in that community, to determine the scope of the work and the purpose of the needs assessment. We also have to work out who else should be involved. We don't want everyone in our advisory committee, but we may need advice. We may even partner with other organisations, so we need to look at who else should be involved, and also what decisions will be based on the needs assessment. So what information do we need, because we need to make certain decisions. So if we know what decisions we're making, we can then identify what kinds of information we're likely to need from the needs assessment. We have to think carefully and critically about what information is needed in order to make these decisions about the kind of project we want and what will go into the project. We also, in terms of gathering data, we just need to gather the data we need, because there's no point gathering a lot of data, because gathering a lot of data and not using it means most of it's going to be out of date, and it's also a waste of people's times if you're collecting data from the community. So only gather what you need. Consider culturally appropriate data gathering approaches tailored to the target population or community and the setting. So for example, if we are targeting an ethnic minority community, we may look at where we can access those communities. We may look at places of worship, community centres. We may look at having focus groups that focus on, women only, or we may focus on men only or young people only, just to make sure that we get full and frank feedback from those communities about what their needs are. Then the third step is analysing the data that we've collected through the needs assessment and understanding it. And then the last step in the needs assessment is reporting and sharing the findings with key stakeholders. And then obviously after that, making a decision on what to do for the project, i.e. that the needs assessment informs the decision making about the project. Step 2 is setting a goal or aim and setting objectives. And an aim is an overall broad statement that describes the desired longer-term impacts of what we want to achieve through our project. And objectives are the specific desired outcomes, the changes we are hoping for from the project. And often objectives are developed using this acronym called SMART, because the SMART acronym helps to make objectives that are more likely to be achieved, more likely to be successful. So it's specific, measurable, acceptable, realistic, and time-bound. So specific means what exactly needs to be achieved in order to attain the goal. And it's about who, what, when, where, how. Measurable means how will we know we have achieved the specific objective that we are hoping to achieve. Because if we can't measure it, then we can't know whether we've achieved that objective. Acceptable is where communities and groups should be happy and accepting of what you want to do in our project. Because if they're not happy about what we want to do in our project, then they're not going to accept the project, they're not going to get involved in the project, and we're less likely to be successful with our project. Realistic, we can't have some kind of impossible goal or objective. We can't cure the world of AIDS or make everyone happy or thin. These aren't realistic objectives or even aims to have. Time bound, they need to be achieved in a specific time frame, often 1, 3, 5 years. It cannot be something like just sometime in the future, or we're not sure when, we'll just carry on and keep the project going forever and ever and hope that our project will be successful at some point in time. No, our objectives need to be realistic and occurring within a specific time frame. So it's an important note here, do not just write about the objectives should be SMART when planning, designing projects. You should give 1 or 2 examples of what SMART objectives are like, and also explain why objectives should be SMART when planning, designing public health projects. There are also different versions of what SMART is in the literature and in particularly on Google searches, often related to business. We have given you the version that best fits with public health. So here's an example of an aim and some objectives, and let's have a look at what we think might be a SMART objective. So the project is a secondary school obesity reduction project. Our aim is to reduce levels of obesity in all secondary schools in Hounslow in children that are studying in secondary schools. Our objectives are reduce the percentage of children aged 11 to 16 years in secondary schools in Hounslow who can be classified as obese from the current level of 25% to 20% in 3 years between 2025 to 2028. Our second objective could be reduce the number of children aged 11 to 16 years in secondary schools in Hounslow who can be categorised as overweight from the current level of 40% to 5% in 3 years between 2025 to 2028. And our third objective could be to increase levels of physical activity in 5 to 16-year-olds by 60 minutes per week, both inside and outside school. And our fourth objective could be increase the amount of green leafy vegetables and reduce the amounts of snacks, crisps, chocolates, biscuits, cakes children eat inside school. And then our fifth objective could be to reduce the amount of sitting, watching TV and playing on computers and mobile devices by 50%. So let's look at these objectives. We can see that the first objective is very precise and it seems realistic. We've got a very specific age group, 11 to 16-year-olds. We're looking at obese children and we're trying to reduce levels of obesity from 25% to 20%, so a 5% reduction in 3 years. And that seems a reasonable objective. But if we look at the second one, that's not a reasonable objective. And it's highlighted in red. We want to go down from 40% to 5%. And that is a huge, of overweight kids. So that's a huge decrease because that includes children who are obese as well. And that's really not a realistic objective to have because it's more than likely that we will be unsuccessful in achieving that aim and any positive we have will be drowned out. So we need to be realistic that we can't in 3 years reduce the level of children who are overweight in secondary schools by 35%. And then the third one is the same. And the problem with this one is not the 60 minutes per week, but it's the bit about outside school. Yes, if it's inside school, then that will be fine. But the fact that it's outside school means this is difficult. How are we going to get children to play 60 minutes a week outside of school? How would we monitor it? How would we look out for it? Yes, we could do it, but over a 3-year period, it would be difficult to check regularly that children are actually doing it at schools, unless somehow we can get parents involved and they are measuring that and they are taking part in something. Maybe you have some kind of software app, mobile, and then all the children and parents are going out for a 60-minute walk on the weekends. Maybe then we might be able to capture that information, but it's not going to be easy and it requires parents to be heavily involved. The fourth one is okay because, again, while it's very general, increase the amount of green leafy vegetables, and in that sense it's not good. We want something better and more specific and reduce the amount of snacks. Because it's inside school, we could increase the amount of salads and other vegetable options in the canteen and reduce the sale of and the bringing in of crisps, chocolates, biscuits and cakes by children, either in the lunchbox or in the tuck shop or buying it from outside and bringing it to school. So we could try that inside of school. But outside of school, of course, children could still go outside. We're talking about 11 to 16-year-olds, so they can go out at lunchtime, and so they could eat crisps and chocolates and biscuits and chips and other things outside of school. And then the last one, to reduce the amount of sitting, watching TV and playing on computers and mobile devices by 50%. Well, again, 50% is huge, and there's also no specific time stated of when we want to achieve that. And again, this is a difficult one to measure. How will we measure the reduction? What would we have to measure it? And as most of these activities are happening outside of school, we could probably reduce the amount of sitting in class. Maybe we could have activities where children get up and do a little bit of exercise in the classroom. We don't generally watch a lot of TV in school, and similarly we don't play a lot of computers and mobile devices. So most of the objectives are actually things that happen outside of school. So it's a difficult one, and it's unclear how we would actually achieve that objective and how would we measure and evaluate that we'd actually achieved it clearly, objectively, without people saying, yes, I've reduced TV, I've stopped playing computers and mobile devices, but actually they are continuing to do so. The third step is identify methods and approaches to achieve our aim. So in this one, this is about how, where and when we will deliver the project and what exactly will be involved in a project. Yeah, for example, a project could hand out leaflets on meditation to students on mental well-being. A project could give students an app on their smartphone to help them do a meditation. A project could buy classes and give them for free or at a low rate in an existing medication class running in a local leisure centre. Or a project could run classes, its own meditation classes, in a local community centre, church, temple, mosque, synagogue, or university. So all of these are all aimed at doing something around mental health and well-being and meditation. But you can see here there's 4 different approaches you could have in terms of how you might go about increasing the number of students who might do meditation. Step 4 is identify resources, and this is about time, money and people. Yeah, people with the right skills, as well as materials, equipment, buildings and partnerships that we have both inside our organisation and outside it. All of this counts as resources that we have to help successfully deliver our project. For example, a project with £10,000 will be different from one that can spend £100,000. It could be run for longer, involve more professionals who are paid in the project, and it could also reach more people potentially. A project developed by experienced people who have run a similar project will likely be more successful than one run by volunteers who have never run a project like this before. A project supported by no other organisations in a community is likely to be less successful than one supported by 10 other organisations in the community. Step 5 is planning and designing the evaluation methods. It is cheaper to build an evaluation at the beginning. If you design an evaluation at the beginning and think about how you're going to evaluate it, it will likely be more successful. Your evaluation is likely to be more successful and it's likely to be more effective. It's more effective because the type of data and how it needs to be collected can be built into the project. For example, a project that gives a questionnaire out after the meditation class or 6 meditation classes and developed it at the beginning is likely to get more real information on success than one that starts developing a questionnaire 3 months after the project has started. This is because evaluations cost money, time, people and expertise, and doing it early means that evaluation is likely to be better and more accurate and more effective in terms of gathering the information that we want to see if the project is being successful. Step 6 is developing the implementation plan. So this is about who does what, when and where. For example, if a public health team develop their own meditation classes, then who will run the class? Will they need to advertise for a meditation expert? Will one of the team train to become a meditation expert? Where and when will the classes be held? How many people can attend at one time? Is it open to adults and children, men and women, disabled people, or only some of these groups of people? Step 7 is implementing and evaluating the project. So your design of your evaluation and your thinking about implementation are activated or actualized or actioned in this step. This step is when the project actually delivers the service to people and actually measures whether that service is having an impact on health and well-being. Some projects can get designed, but then for different reasons, lack of money, changing priorities, don't get implemented. Some projects have an evaluation plan, but for financial reasons or lack of staff, do not then do the evaluation. It takes time, effort, motivation, and commitment to make a project happen. Now let's move on to the PRECEDE-PROCEED model in more detail. So the PRECEDE-PROCEED model, the name is actually an acronym. So PRECEDE, the word, means something that comes before, but it also stands for predisposing, reinforcing and enabling constructs or causes in educational, environmental, diagnosis and evaluation. Essentially, this is an acronym of the key steps within the PRECEDE-PROCEED model. And proceed means, as a word, means going forward. and is also an acronym for policy, regulatory and organizational constructs or causes in educational and environmental development. We went through this in more detail in session 1 here. I just want to go through this again very briefly, and then go and look in more detail at the strengths and weaknesses and similarities and differences. So in terms of, there are in the precede phase, the first 4 phases of the precede phase, there are 4 assessments. There is a social assessment that involves looking at the quality of life, and it involves talking with communities about what is important to them, and then that feeds into an epidemiological assessment where we look at current health status, current health behaviours, and the current environment that people live and work in. And so these 3 factors form the epidemiological assessment. We don't look at genetics, very rarely do, so you don't really need to think about that for your assignment or in the future, but it's just helpful to be there because sometimes you may need to think about it. And then the 3rd phase is the ecological and educational assessment, and that is about the predisposing factors that lead people to get involved in risky behaviours. The predisposing factors are the negative factors that affect people's health and well-being, that make them do risky things. The enabling factors are the positive factors that help people to get involved in and take up positive health behaviours. And the reinforcing factors can either be positive or negative. They can reinforce predisposing negative factors or reinforce positive enabling factors. And so we need to look at people, talk to people, look at communities, observe communities, look at the wider environment in communities to try and understand what are their predisposing, what are the risky factors, what are the attitudes, beliefs, behaviours, knowledge gaps that people have that lead them to risky behaviours, as well as looking at what are their positive assets in terms of knowledge, skills, abilities, and the wider environment that might help them to take up positive health behaviours. And then the 4th phase is administrative and policy assessment, because what we want to do is align our intervention to existing policies, regulations and organisational aims and objectives. And we also want to look at the educational strategies that we may have in our health programme or health project, and through that these 2 things, we can ensure that the health project, the health programme, is more likely to be effective and more likely to be successful in delivering the aim and objectives that we have set. And then the proceed phase is from phase 5 to phase 8 is implementation, and then it's the 3 sets of evaluation: process evaluation, impact evaluation and outcome evaluation. And most of that part of PROCEED is about monitoring and evaluation and continuous quality improvement, because quality is a part of evaluation, because we want to run a high quality project, a high quality service, a high quality program, and so it's important for us to evaluate it to make sure that we are meeting the needs of the target community. This is another version of this diagram, and in this diagram we lose the genetic component, and instead of behaviours component has been changed to lifestyle, but essentially it's the same thing. There's a few more words and descriptions that I think is worth for you to have a look at, and it's found in the Naidu and Will's book that is a core foundations for health promotion. The strengths and weaknesses of the general planning model are that the model is more detailed and has clear, easy to understand steps compared to Hobley's model, the first one we looked at in the last session. However, its weaknesses are much greater. It's not explicitly participatory, it does not have a step where communities are engaged and involved, and it doesn't ask communities what they would want. It's a very top-down model where public health professionals decide what kind of project should be delivered. And despite the increased detail, it still is a difficult model for new and inexperienced public health professionals to use, because there's not enough detail. There is more detail, but it's still not enough for new people to get used to and understand how to use the model. And lastly, it's not specifically focused on public health and health promotion. So what are the strengths and weaknesses of the PRECEDE-PROCEED Planning Model? Well, this is a very detailed model and tells us clearly what steps to take to develop a project. It is comprehensive. It covers all the key things that we need to think about when designing a project. It is specifically developed for health promotion and public health. However, and these are the negatives, it is a complex model. Some of the steps are difficult to understand. Some of the steps are likely to be difficult to do well as well. And then in terms of further positives, it starts with what the communities want. It starts with the desired outcome, what communities think will improve their health and well-being and improve their quality of life. It's therefore a participatory model, and it explicitly includes communities in the design and planning of the public health intervention. It also takes account of national and local policies and existing services and projects, and makes sure it links with them, works in line with them, does not work against them. The resources it also looks at are skilled people, time, money, equipment, buildings, partnerships that a public health profession and organisation have that they can use to improve and deliver the project. It also looks at channels of communication to target groups, different educational strategies and different channels, social media, local newspapers, local TV and radio. And lastly, it's a holistic model. It uses an ecological model or ecological approach to developing health promotion, public health interventions and projects. It looks at all the determinants of health acting at different levels: individual, family, community, neighbourhood, population. Think about how these levels and the determinants at these levels affect the project. It tries to act at all these levels, or look at what is judged to be the best level to act on for the project, the most effective level. So let's look at the kind of similarities and differences between the general model. Well, in the general planning model, we just talk about needs assessment, but in the PRECEDE-PROCEED model, we talk about both a social assessment and an epidemiological assessment. Therefore, the PRECEDE-PROCEED model explains that it should have two parts. We need to have public health statistics, indirect information about the population, as well as direct information about the population by talking with communities and understanding what their needs are and listening to what their wants are. What do they think is important to improve their health and well-being and their quality of life? The general planning model does not explicitly discuss this. The PRECEDE and PROCEED model discuss predisposing factors, enabling factors, and reinforcing factors. As I said, predisposing factors are the individual factors that lead to risky behaviours, such as poverty, lack of education, shops not selling fresh fruit and vegetables. And enabling factors are individual factors that will support the intervention and help people change their behaviours. And reinforcing factors are the wider family and community factors that might make it easier or more difficult to adopt healthy behaviours. So the PRECEDE-PROCEED model identifies three key factors besides the determinants of health, or as part of the determinants of health, that need to be investigated to make sure a project is successful and works to improve people's health and well-being. Again, the general planning model does not explicitly discuss this. Then the PRECEDE-PROCEED model also looks at the policy and administrative aspects within which the project is located. Is the project intervention aligned to, fits with existing national and local policies and regulations? Are political, organisational and administrative structures able to deliver, design and evaluate the project? What existing programs, services and projects are running, and how do they link into the new project? Is it duplicating existing projects? Can it work in partnership with them and therefore save money and time and effort? Could political, organisational, administrative aspects make it more difficult to design, deliver and evaluate the project? And in which case, how can we reduce the political, organisational and administrative barriers? Finally, what resources are there? Skilled people, time, money, partnerships, equipment, buildings, social and news media that can help us improve and make the project more successful. Again, the PRECEDE-PROCEED model explains this aspect, that political, organisational and administrative aspects need to be considered, but the general planning model does not explicitly discuss this. Lastly, the PRECEDE-PROCEED model looks at three types of evaluation: process evaluation, impact evaluation and outcome evaluation. Was the process of designing and delivering the project done in a good way? Yeah, were people involved? Did people like the process? When people use the service, the project, do they enjoy using it? Do they feel welcomed into it? These are really important things. Impact evaluation is about what are the short-term benefits to health and well-being of the project. And outcome evaluation is what are the long-term benefits, a year or 2 years or 3 years on from when the project started. Did people's health improve because of the project? Or was it something else or some wider social factor? So again, the PRECEDE-PROCEED model identifies three types of evaluation that need to be measured to make sure a project has been fully successful. The general planning model does not do this. Lastly, we just need to talk about what is the ecological model and why is the PRECEDE-PROCEED model ecological. So the ecological model is simply an approach that looks at all the factors that might affect an individual and a community and their health and well-being. And so that includes both the individual and the physiological pathways and the genetic factors and the individual risk factors like unhealthy eating or lack of physical activity or risky sexual health behaviours or any other type of risky activity that may lead to a potential future disease. But it also considers social relationships, the housing and living conditions, the neighbourhoods and communities that people live in, whether they have jobs, the institutions and services that they can receive and are able to access, and the social and economic policies within which they are living in terms of the national social and economic policies and the local social and economic policies. For example, do they have free healthcare? Do they have access to benefits when they are unemployed or they're disabled and can't work? Are they supported when they're elderly and they can't cook for themselves and can't go out to do the grocery shopping? Are they being supported through health and social care services? This is another model, similar one, but perhaps makes it more easier to see the kinds of issues we might think of. So at the centre, we have the individual and their sex, their age, their existing health status, but around them in the microsystem, they have their family, they have the school, they have their friends, peers, they have the neighbourhood and the neighbourhood aspects like play areas and footpaths and good roads and safe crossing points. They might have places of worship like the church group or other community support groups that can support and help them. And then around that, you have the exosystem, which is wider friends and family. We have neighbours, we have legal services, social welfare services, we have the media who inform us about health and well-being issues. And then in the wider macro system, we have the attitudes, ideologies, the wider social norms, the cultural aspects that we all take for granted. And even wider outside of that is the chronos system and how things change over time. So we need to think about, in our project, we need to think about all of these things. That's how the PRECEDE-PROCEED model becomes complex, because it's trying to take account of all these wider factors in the project. It's just not trying to deliver a project to try and meet a single aim. It's trying to look at all the wider issues and how that might impact on the project and how might that stop people from taking up and using that project in a way that improves their health and well-being. Now you will need to look at this in more detail and reflect on these models and think about these models. That's the best way for you to get a deep understanding, by thinking and reflecting on them, trying to find your own examples, trying to create your own examples of how this will work, by thinking about where you live and work, and think about your friends and family, and think about how they fit into these models. So the ecological model or approach can help to systematically identify all the factors that can influence, affect the planning and design of a project. Well, I hope you enjoyed this session. Please think about what one point you will take away from this, and also think about what one thing you did not understand or you found confusing, and please use the peer support forum or the shared Microsoft Word document in this week's folder to add your question in, or your confusing point that you don't really understand at the moment, and we will look at that in the next session. And thank you and goodbye.